Hey everyone, welcome back to another virtual morning report. Good morning, good afternoon, good evening, wherever you are in the world. Thanks so much for joining. And I'm here today with Alec and Mengyu, and hopefully one of you in the audience can help us out with the case. We're looking for one, so please don't be shy. Message in the chat, say if you have a case, and we'll be happy to talk through it. But if not, fortunately, Ibrahim has a backup case for us, so no worries if not. But if you have a case that you'd like to share, even if it's not prepared or anything, that's totally fine. We'd be happy to tackle it. But really excited to discuss again today because it's been a little while. So we'll just monitor the chat here and see what we find.
Yeah, again, so great to see everyone and seeing so many familiar faces. My name is Mengyu. I'm a CP Solvers team member and a hospitalist currently practicing in Portland, Oregon.
Yeah, and I missed the last one. My name's Alec. I'm a hospitalist at Baylor. I am renting a desk in Zavin and Steph's office. And I missed the last one because I had another baby. So I've just been busy with that. And yeah, Austin also just had a baby. So just exciting times all around. Okay, so anybody have a case they'd like to present, or we're going to have to rely on Ibrahim to present? I know he'll have an excellent case, but okay, I guess we can wait till 5 past the hour and then just defer to our good friend. Carolina, that's quite the picture of presumably your cat there. That's mid yawn, takes expert photography there.
Yes, it's my cat.
How's everyone doing? Ja, if you can speak up, I'm curious, are you in the US or in China?
I'm currently in the US and just finished my step 3. Yeah.
Congratulations.
Wow, congrats.
Thank you.
All right, well, I think Ibrahim, you're up. Thank you so much for having a case here, and if we can pull up the whiteboard, I think we can get started.
Okay, my pleasure. So do we have the scribe ready or?
Is
If Dia's not here, I can scribe. Taisha.
I don't
That would be
see.
great.
Yeah, that would be awesome.
Let me just get the whiteboard. Just give me a second, sorry.
Awesome. Thank you, Leah.
Can I be made co-host, please?
Okay, did it work? All right, awesome. Thank you.
Yeah, also before we start, if you could please start the recording.
I think I already did, hopefully.
It looks like it's recording in the top at least.
Okay, that's great.
I didn't mess up. I didn't mess up this time. Thank you so much.
So whenever you're ready, I'll be ready.
Yeah, we're all ready.
Take it away.
Okay, so for the chief complaint for this patient, This is a 33-year-old male with bilateral alternating upper back pain at both scapulae that had started 3 months ago.
I wonder if I should start first, but this just reminds me of Kuchel's case recently with the musculoskeletal presentation that Kuchel presented an awesome case on Sunday. So yeah, bilateral alternative back pain in both scapula for the past 3 months. As a 33-year-old male, I think common things being common, still like musculoskeletal, like common things are like muscle strains. I would be curious if there was any inciting, any triggers prior to the symptoms developing, any muscle strain, and what makes it better or worse. Although, like also on the other spectrum of the thinking is something more serious, like in a 33-year-old male, you would be thinking about things like ankylosing spondylitis or things like that could mimic like musculoskeletal pain, but have to be taken seriously. And those are my initial thoughts. I'll just pause here and see if Alec and Austin has things to add.
Awesome. Great start, Mengyu. So, I think a very interesting chief complaint, not something that I typically see. And I think it would be helpful to get some more information about, the alternation. Is it really just one side, then the other side, one side, the other side, and then the duration of the symptoms, how long they last, whether the associated symptoms, whether there's a systemic signature to this, or whether this is truly just isolated pain. And then, MSK pain and even, pain in the muscles just in general. I've been fooled so many times about pain that's not actually in the muscles, but it's referred to the muscles. For example, during the Academy via VMR recently, testicular pain and discussion with a case about referred pain from the retroperitoneum. So this could be, sometimes diaphragmatic issues can radiate pain to the scapula, or could this be, something in the upper back as well that could be contributing, and whether or not there may be lower back symptoms. So I think very interesting. I'm noting the alternation here and the bilateral nature of it as well. And just going to need additional clarification on the history and the time course and the background as well, to get a better sense of what exactly we're dealing with. Austin, what do you think?
No, both of you have set things up beautifully, and think what both of you are trying to do is I think we're still trying to define the problem. Right now we could solve the problem with bilateral scapular pain or bilateral shoulder pain, but if we try to lay in the time course and we try to layer in the intermittent episode, the nature of this condition is intermittent, then that really changes like how we would approach the problem. So I think right now it's so open that it's hard to define what the problem is exactly in order to solve it. But the fact that it's intermittent, getting more clarity on what that means, but it reminds me of kind of Reza's approach to when something's intermittent, what is the trigger? It's like, what triggering it? Is there a trigger? Is it exertional? Is it positional? Is it environmental? Is it emotional? We don't know what it is. But I think that can help us make some diagnostic progress. And then Hans also greatly mentioned about the time course here. We're sort of labeling it as acute, or chronic, excuse me, given the 3 months of symptoms. But is it really chronic? Depending on if the nature is like, oh, it's intermittent, like it lasts for 5 seconds, 15 seconds at a time. I'm going to approach that differently than like, oh, I get it and it lasts for a week at a time, or I get it and it comes and goes every single day, lasting for hours. I think all of those things are going to change the way that we think the case. So really excited to learn more from you about how to further clarify what the problem is so we can solve it.
Okay. So moving on to the next aliquot for the HPI for this patient. Once again, this is a 33-year-old male with a 15-pack-year smoking history, status post his second kidney transplant 7 years ago, who's now presenting with bilateral alternating upper back pain at both scapulae that had started acutely and is not worsening in nature. The patient ranks the pain as 8 out of 10 and says it's associated with movement of upper extremities and the trunk. He denies any weakness, sphincteric incontinence, neurological symptoms. He also denies any history of fever, night sweats, loss of weight, or any other systemic symptoms.
Oh, wow.
Well,
Very interesting background of the case, especially with the kidney transplant and second kidney transplant. I wonder how long it's been since the kidney transplant, because I think there's a window where the patient will be on a different the immunosuppressant regimen strength will be a little different, and so the degree of immunosuppression will be different. And so we would like definitely think about infection, although it's also interesting, patient doesn't seem to have any systemic symptoms to suggest infection. And you would also think about any side patient, will be on a lot of medications if there's any side effect from these medications. And with the heavy smoking history, depending on how much he smokes, you would think the risk of malignancy or associated. So that would be on the consideration. Also would be curious what the underlying reason for the kidney transplant. I think so far very interesting, but still looking for more information. Actually, maybe I'll pause here. I feel I'm a little disorganized in my thinking, but curious to see what Alec and Austin thinks with these additional information.
No, awesome, Mengyu, so far. And I think just a really interesting sprinkling of the background here. And like you had mentioned, really important to know when the last transplant was, why they received the transplant, potentially what immunosuppression was there, what complications they had related to the procedure, what's the graft function doing. And I think it would be helpful to clarify for me, and I'm sorry if I just missed this. So is it the patient is getting bilateral scapular pain and then it goes away and then it comes back? Or is it gets pain on one side, then gets pain on another side? And then, how long this is lasting? It seems like there might be some exertional use trigger to this. But I think I don't, and like Austin had mentioned before, have a true grasp of the problem. It's very interesting that there's a lack of systemic signature at this time, but if the patient is immunosuppressed, we may not see some of those things that we would typically associate with that. And then this movement related to the upper extremities, I wonder if this is related to exertion as well, whether there could be, some sort of ischemic component or whether there's some sort of attachment there, and whether or not the background is definitely important, but whether it's truly related to the presenting complaint, I think will be interesting to determine. So I think still quite a few unanswered questions, at least that I have regarding the history. And then I think the physical exam will be extremely telling, because if the patient says they have pain here and you go to examine said area and there's no pain there, that could be really helpful diagnostically. But Austin, what do you think so far?
Again, I like the alley from both of you. It makes my job a lot easier, so thank you so much. But no, I think, Ibrahim will fill us in a bit more, but if I step back and say, okay, there seems to be a movement-related exacerbation of the pain, how can I help? How does that help us diagnostically? I think the first instinct to say, hey, okay, there's something anatomical here happening, so either at the level of the muscles or the bones that's causing symptoms, and that's what we classically see if someone is having shoulder pain, like in the clinic, for example, or scapular pain in the clinic. But I think the other aspect of this is either a neurologic component, which, based off the history, is not having numbness, tingling, anything else like that. And then the other phenomenon to think of is a vascular phenomenon. So is there, blood flow related issue, like almost an anginal type situation, but like thoracic outlet syndrome or something like that. However, that doesn't really manifest as a shoulder thing. And then the lack of any sort of neurologic, like positive neurologic symptoms from this tingling sort of lower that down on differential. But I think we have to step back and say, oh, this is a 33-year-old with a second renal transplant. So I think whatever the primary disease was that led to these transplants could be very helpful in helping us to frame the problem. Maybe it's unrelated, like this person had rheumatic disease and then developed, some other strep-related complication, but it usually doesn't lead to CKD. Maybe there's IgA, maybe there's some other childhood illness that I cannot remember, because unfortunately my pediatric days are far behind me. But I think getting further information on that will help us make progress. And Ibrahim will fill us in. Such a great case so far.
So thank you all so much. And before moving on to the past medical history, I just would like to clarify the point that Alec has brought up. So the pain was described as alternating because it seemed that the patient described that alternating in both sides, and it almost always happened with movement. So it seems that there's definitely some exertional component to it. So for the past medical history for this patient, they were diagnosed at the age of 5 years with vesicoureteric reflux. And at the age of 7 years, they underwent dilatation of both ureters. And then at 11 years of age, they started hemodialysis. And then 2 years after starting hemodialysis, at the age of 13 years, the patient underwent his first kidney transplantation at a nearby hospital, and the donor was his paternal aunt. However, this transplantation was complicated by chronic graft versus host disease and renal failure. And then he underwent his second renal transplant at 26 years of age. That was 7 years ago. And the donor at that time was his sister. For the medication, he's on over-the-counter NSAIDs for back pain that had started 3 months ago, which are only helping minimally. He's also on mycophenolate, 1,000 milligram BID. He's on tacrolimus, 1 milligram AM and 0.5 milligram PM. He's also on prednisolone, 5 milligram every other day. For the family history, it's non-remarkable. Both parents and all siblings are alive, healthy, and free of disease. For the social history, he works as a teacher. He's married, but he has no kids. For the health-related behaviors, he does not consume alcohol. And apart from the 15-pack year smoking history, he doesn't have any other health-related behavior. And for the allergies, he doesn't have any known allergies at the time.
Yeah, wow, very rich past medical history. I think overall, I think with a very helpful information during the Alec what you just gave us is that the fact that the pain worsens when the patient moves, like it's associated with moving. But it seems to be bilateral, like something involves both sides. So like a muscle or bone, like a more diffuse bone involvement or joint involvement, I think are still on the differential. The fact that it's already 7 years out of the transplant, I think, although patient, is taking the immunosuppressant, so it's still definitely at risk for associated complications like infections or, but yeah, I wonder what additional thoughts you have, Alec and Austin.
Yeah, this is, a perplexing case so far. Vesicular ureteral reflux, that just could be, something that unfortunately he was afflicted with, or could potentially be component of a genetic syndrome associated with other congenital abnormalities that we haven't really picked up on yet. And, some of those genetic conditions could be, associated with autoimmune disease or anything else, for example, like CVID or something like that, though I wouldn't necessarily associate that with the reflux. So I think that's interesting. I think as well, getting a sense of where we might prioritize infection on the differential. Certainly there's a lack of systemic signature, but the patient has been chronically immunosuppressed, for 20 years related to 2 different transplants. So I think it partly could be helpful to know what they received for induction and how this transplant has been going. Seems like the prior one was really complicated by chronic graft versus host. So I think getting some additional background on that might be particularly helpful. Now, the NSAID use in a patient with a renal transplant is always makes me a little bit nervous. And so getting a sense of how frequently they've been using them and how much they've been using it, and whether the timing of using the NSAIDs has led to the associated symptoms, or what exactly at the time 3 months ago, if there was a triggering event to the back pain. Did they get in some sort of injury? Did they do some sort of exercise they don't typically do? And I think that will also be quite helpful. And, I think other associated symptoms, lymphadenopathy, hepatosplenomegaly, things like that. People that have had prolonged transplants, you always have to think about PTLD also, which would be something to consider. Although, again, I'm having a hard time translating that into necessarily the scapular pain. And then I think as well, like where the kidneys were transplanted. Did one go on one side, one go the other? Did they take out the first one when they put in the second one? Because in theory, I guess, depending on where they implant it, if it's pushing up on associated structures, could lead to referred pain. I'm stretching a little bit, but I think it would be helpful to know if it was bilateral on both sides. And then, with chronic steroid use, you always have to think about the side effects of steroids, including osteoporosis. That's somebody, I think somebody mentioned that in the chat, but whether or not they could be predisposed to having just a predisposition to having fractures or other bony disease. And, I'd have to really delve deep into the more long-term side effects of MMF and tacrolimus, which I don't have a good handle on off the top of my head. So those are all just a few things I'm thinking about. And then in addition to this scapular pain, whether or not there are other associated sort of bony symptoms or muscular symptoms, or is this really the only site? And again, I think the physical examination will be extremely helpful to know if there's, for the most part, most muscular and bony issues, you can pinpoint that on exam, whereas referred pain sometimes can be a lot more difficult. So I think that would be a helpful next step. And Austin, what do you have to add to that?
Nothing. Beautiful discussion. Interested to hear more.
Thank you all so much. So moving on to the physical examination for this patient. For the vitals, he was afebrile. His heart rate was 93. He was normotensive. His respiratory rate was 13, and his saturation was 98% on room air. For the general examination of this patient, he was alert. He was mildly distressed. For the head, ear, nose, and throat, it was non-remarkable. For the cardiovascular, it was S1, S2, no murmurs, no thrills, no elevated JVD, no pitting edema. For the pulmonary bilateral air entry, no rales, no crackles, no rhonchi. For the abdomen, it was soft and lax and not distended. For the neurological examination for this patient, for the reflexes in the upper limb and the lower limbs, there were 2+. The power was 5 out of 5 in all limbs. On back examination, the patient did not have kyphosis. However, he did have paravertebral muscle spasm and midline tenderness at the thoracic spine. The range of motion in the thoracolumbar as well as the cervical spines were limited due to pain. And finally, for the extremities and the skin, they were non-remarkable.
Wow, very interesting exam. I think what really jumps out is, again, lack of systemic signature, but the tenderness over the midline area of the thoracic spine and some I think paravertebral tenderness could be associated with like some muscle spasm, but like the midline tenderness really points towards some. For me, I'm thinking more about bone pathology over that area, and I guess if there's any joint or associated structures like tendons is possible, but I think really bone seems to be the most concerning structure over that area that also seems to associate with the symptoms the patient is having. I think in terms of bone association with bone, like I think the chat has some really good thoughts earlier, which is like any pathologic fracture or or like an osteonecrosis or along similar lines. I feel like people are usually not on a super high dose of steroids many years post transplant, but I think still could have a history of really high dose of steroids used in the past. So I think that still definitely put him at risk for that. And infection, I think, again, still on the differential, even without the lack of systemic signature, given the immunosuppressive use. Right now, I couldn't find any association with the tacrolimus, although tacrolimus has a lot of interesting side effects, but like TMAs or like a lot of vascular issues. But I think so far I wasn't able to connect to that yet, but I might have to read more about it. Yeah, how about you, Alec and Austin?
Awesome. Feel free to take it and I'll do after.
Okay, great. Yeah, no, those are great thoughts from you. And Ibrahim, just can I ask a clarifying question? When you did your exam, like when you're assessing the power, like did that worsen their pain? Were there certain movements that seemed to exacerbate the patient's pain, or just movement in general seemed to cause issues?
Yeah, so it seemed that the patient in general was actually distressed due to the pain that they had. However, we were able to examine the power and the reflexes, even though they were showing some signs of pain at the time.
Okay, thank you so much for clarifying that. And I think if we step back here and say, Ibrahim's an expert clinician and does wonderful physical exams, so I feel, I can trust it 100%. But if I step back and ask myself, okay, how reliable is detecting muscle spasms on exam for someone who comes with back pain? And the answer is it's not at all. So we think that we feel muscle tightness, we think that we're feeling this, but most of the time it's completely non-specific, where we are not actually thinking that we're not actually feeling what we think we're feeling. So how much weight to put in that in real life, I think, is a bit challenging. But for the purposes of this diagnostic exercise, I would say, okay, this person has a pretty significant muscle spasm in the area of where this patient is having discomfort, right? So I need to solve the problem of thoracic paravertebral muscle spasm potentially, right? So what can cause muscle spasm? And I think to myself, okay, what can cause the muscles to contract in themselves? So you need calcium and electrolytes, right? So for that to be isolated to just the back muscles would be really, really unlikely without any other systemic signs, right? So I don't think it's more of a systemic process that's affecting the muscles, like electrolytes, for example. This also includes like a neurologic, like the nerves or the neuromuscular junction. I think that'd be really, really unlikely. Then we could think about, why muscles might spasm without signal to do so, or without appropriate signal to do so, like dystonia or something like that. So, focal dystonia is, I suppose, there's case reports of it causing it in the back, but I'm not familiar with those. But that will come to mind. There's a recent discussion as well on VMR about stiff person syndrome. And we're not really hearing any other features of that. There was no hyperreflexia. We've not heard of the startle reflex. We've not heard of any other, in the demographics and epidemiology don't really fit perfectly with stiff person syndrome. But some sort of primary neurologic disorder would be a consideration. Then we can think, okay, the spasms are reactive to something. So everyone's already mentioned about how the medications and the immunosuppressed status and the transplant affect the health of the bones, and why this person could be at risk for fracture or any other bone pathology. And so whenever there's underlying pain or bony process, you might have muscles contracting as a reaction to that. So I think assessment of the bones can be paramount. And if we step back and say, okay, if this person came to clinic, would I get and we didn't have all this history, would I get imaging of their back? And the answer is probably yes. And the reason is because when we think about sort of the red flags of back pain, all those really apply to the low back. When you're having pain in thoracic spine or higher, that is actually a red flag, especially where the pain is. So even in the absence of this person having had a transplant, been on immunosuppressants, the steroids in particular, I would still image this person up front. And that's unique to the thoracic spine. And that was a learning point for me in clinic, and that's a case I can share with you guys another time. But I think, how to make diagnostic progress from here, you guys already gave excellent thoughts, but I think we're going to have to solve this problem. I think we're going to need imaging. I would start with an x-ray probably. I don't think x-ray is going to be high yield, so we're going to need more advanced imaging because I'm not going to feel good enough about the x-ray itself. And certainly be open to referred pain, as everyone talked about before. So Alec, what additional thoughts do you have?
No, awesome. That was awesome. Really thinking about other things that could be contributing and break it down from a sort of neuroanatomical approach. And, I think because Ibrahim, we know, is going to do such a reliable exam, I think the fact that the patient has point midline tenderness in the thoracic spine really just narrows my differential down a little bit to the bony pathology of the spine in particular. And I do feel like you had mentioned, without another clear systemic signature or neurologic findings on the exam, that we're more likely to be in a reactive paravertebral muscle spasm, and that the money's going to go to the bones. And I agree. I didn't really know much about the thoracic leading to like having to prioritize the imaging sooner. I just presumed with the patient's age and the severity of symptoms that I would probably do that anyways. But that's a good learning point for me as well. But yeah, I think the MRI, hopefully if we're able to get that in the resource limited setting, I think it's reasonable to start with an x-ray, because if you find something, that's useful. But you're right, if it's negative, it's not going to be sensitive enough not to do anything else, especially given the chronicity of the symptoms as well. And then, I'll just give a plug here. If it does relate to bony issues, there was a great Core IM podcast on steroid use and how sort of chronic steroid use, even at low doses, can lead to all the side effects that we think about. So I recommend you give that a listen. But really interested to learn more if there's any signal in the labs, particularly in the imaging. So Ibrahim, what you got for us?
Yes, so the consultant or the attending that I was working with, she had a couple of differentials at the top of her head. And so because this patient had presented with chronic pain rather than acute in onset, she decided to immediately go for an MRI, particularly also because MRIs are readily available at my institution, and because of the patient's risk factor and that they are a patient with history of chronic kidney disease and multiple transplantation. And so on imaging, the MRI showed a T6 fracture with midline cord compression. However, obviously that's not the final diagnosis. So as soon as she actually saw what the MRI had shown, she ordered the lab test. And then following on with the lab test, the patient went on to surgery, but I'm gonna let you or give you the chance to discuss that.
Yeah, wow, yeah. So I think thanks for this piece of aliquot. The findings, the T6 fracture, which I think also confirms our concern about a bone pathology here, and I think midline cord compression, that's absolutely like an urgency. So I see why a patient went to the surgery. But then the question is, why did the patient develop a fracture in the thoracic spine, especially in this young age and without like a clear trauma, and we haven't heard about like a huge trauma prior to this. So, so it's like a pathologic fracture. So I think now the point, the discussion point is like, what's the cause of the pathologic trauma? I think patient definitely has a few risk factors that we mentioned earlier, including the steroid use and the potential like a vascular like a lack of a blood. So yeah, like steroid related, or if there's a hitting infection. Actually, recently when I was on service, there's a patient similarly came in with a fracture, had surgery, but turns out later the blood culture came back positive. So I think it's still possible that there's an infection hiding there. And then I think Ambush mentioned in the chat actually about renal osteodystrophy. So like whether this patient has some sort of, if the renal function is chronically, having poor renal function, is there tertiary, like hyperparathyroidism or things like that has caused osteoporosis type of pathology and leading to fracture. I'm trying to see what are some other differentials for like pathologic fracture, but I'll pause here.
Yeah, I think it's good to know that the MRI confirms sort of our clinical suspicions. But like Ibrahim and everybody else says, we still haven't determined why this patient has a fracture. And certainly, like Mengyu said, the steroids are probably the culprit I'm going to most likely to think about. But given the chronic immunosuppression, do need to think about other infiltrative things that could go to the bone, and thoracic spine being most common, just because there's more of the T spine than the L spine or the C spine, right? So I think we didn't get any of the labs, but it would be interesting to know if there's any other systemic signature, hypercalcemia, or elevated alk phos, or anything else that could maybe tip us off from one thing or another. And then Ibrahim said there was a diagnostic test that was ordered. So just trying to play into the diagnostic exercise here. What other lab tests or things would I want to do in this instance? And certainly getting some pathology when the surgery is done, I think would be extremely helpful to look at the bone architecture to see if there's any underlying signs of infectious disease, granulomas, whatnot. I think a vitamin D would be very helpful as well, just to get a sort of quick sense of the bone health. It doesn't seem like the patient was on chronic supplementation. A lot of times if people have enough dietary intake, you don't always need it, but I think that would be helpful information to know as well. And beyond that, I think getting a sense of the graft history just for more of my interest, I think would be good, but whether or not that is going to help me diagnostically, I'm just a little bit unclear about. I mean, I guess if the the patient has significant advanced CKD in their graft, that may point more towards renosteal dystrophy or something else. But beyond that, I'm sort of drawing on a blank. I don't know, Austin, what do you think?
Well, I think you guys have explored everything, and thanks so much for bringing this, Casey, for me. It's led to a great discussion. It's going to be lots of learning for me. But I think the first thing I want to comment on was, this person has core compression of the thoracic spine with a normal neurologic. We didn't see any signal on the exam that this person has core compression. Now, he didn't, unless I missed it, he didn't share with us like sort of the degree of core compression. It was just like a facing the cord or just complete compression. But I think this is one of I came across a case in my clinic recently of someone that had a thoracic myelopathy, and it could be very, very challenging to diagnose. So because a lot of the things that we do on a neurologic exam aren't really specifically testing the thoracic spine or the area of the T-spine, right? Very rarely are we checking like spinal levels on someone, for their sensory levels, excuse me. We're checking the reflexes, but none of the reflexes that we usually check are assessing the thoracic spine. Even assessment for strength is really not assessing much of the thoracic spine at all. So I think it's always humbling to see a case like this where you're seeing cord compression, and unless you had pain right there, would you have ever ordered an MRI or a scan of the thoracic spine? No, right? You wouldn't have. And I think that's what's particularly challenging about the pathology of the thoracic spine and the thoracic cord itself. So I think that was interesting, and but obviously Ibrahim and his team are all over it. So then if I step back and say, okay, we have bony pathology at T6, it's a fracture. What might contribute to fracture? You guys already talked about everything, but if I layer in, okay, what are the bony complications of renal transplant in particular? I really don't have a robust illness script, so I'm excited to learn more, but I think infection is something that really comes to mind. Sequela of the medication, as you guys already mentioned. And then, tumors. This person has been immunosuppressed for many years and is at risk for cancer. And you always wonder, okay, underlying this fracture, is there some other lesion? And then, really being thoughtful about doing to investigate other areas of the spinal column to make sure there isn't another signal for bone pathology, or asking about, do you have other sites of pain that maybe weren't as important to the patient or as bothersome to the patient that didn't mention? Other than those, I think I just don't know enough about it, so I'm excited to learn. And as far as a test, I think, Ibrahim, I don't know if it was a blood test or what exactly was ordered, but I think vitamin D is interesting, PTH, and maybe the calcium, the blood cultures. I think everyone mentioned that. So I'll be hard pressed to select one thing. But Ibrahim, fill us in. This is such a great case.
So actually, thank you for your comment regarding the mild cord compression, because I was also confused about this. Like, I examined the patient myself, and then also the attending went on and she confirmed the findings. And the way she explained it was that because this patient was on chronic steroid use, the inflammatory response in these patients usually is much more less in comparison to the usual population. So even if they do have a cord compression, particularly if it's mild, they still won't show symptoms. And the way she gave an example was the example where a patient who would present with metastases to the spine, and then you would give them IV dexamethasone in order to relieve their symptoms. She compared and contrast this patient with a patient who would present with a spinal metastasis, and you would use steroids to actually relieve their symptoms. I do have to say, however, that regarding the CBC that this patient had, apart from the anemia that they had of 9.6 of hemoglobin, it was normal. The chemistry was also particularly normal, even though this patient was a recipient of a kidney transplant. And for their and then for their creatinine, it was 73. And it was actually very similar to their prior visits. So there was not a marked change from their prior outpatient follow-up. However, this consultant had actually ordered an LDH, and the LDH came back of a 2,252. And because of this LDH, the patient went on immediately into surgery. And when they went on into the surgery, I think Alec had mentioned this, they underwent a spinal fixation of T2 to T6. However, they also had a biopsy. And the biopsy finally, I'm not going to say the diagnosis, so Maybe I'm gonna I'm gonna get you back the case so you can discuss it, and then after you can discuss it, I can tell you the final diagnosis that this patient had.
Yeah, wow, amazing, Ibrahim. And that is a very interesting finding, the LDH. I wonder how your attending thought about checking this, because I wonder if it's because of the concern about a malignancy causing a pathologic fracture. So like a post-transplant, like lymphoproliferative disease, or like lymphoma or things like that could always be other differential. I wonder if that's a reason for checking the LDH, and with that, I think lymphoma would be under consideration, because like normally LDH would, like any breakdown of cells, you would expect an elevated LDH, but this degree of elevation seems to be really high for compared with what we see on the imaging and systemic evaluations. So yeah, I'm really puzzled by this case.
Go ahead, Austin.
Okay, yeah, wow. It's such an expert presentation and case, and thank you so much for bringing it. And yeah, I think we're all sort of attracted to the LDH as the so-called like lymphoma detection hormone. So we're always going to think about lymphoma and someone that has an elevated LDH. If I challenge myself a little bit more, and then you already did this and said, hey, okay, when the LDH could be a sign of just cell turnover or death of tissue in general. I don't really think of the bone, like if you infarct the bone, like would you have elevated LDH? I don't know enough about that to know for sure, but my gut feeling is like compared to like the liver or the kidney or the lung or something like that, wouldn't expect to see that. But other things that can sort of mimic lymphoma would be sort of tuberculosis, or whatever TB can do, histo can do better, as Dr. Restrepo said a while back. And so I think, I'm not sure epidemiologically, like that type of like fungus would make sense. But that would also be a consideration. And again, assessing for other sites of bone involvement or any other involvement would make sense. And then I really love Ibrahim's teaching point about the prednisone. That sort of crossed my mind. Maybe even between the NSAIDs and the prednisone, they could have masked some of the symptoms. I know it didn't seem like we found that particularly helpful. I guess the other argument on that side is that prednisone 5 milligrams every other day. I think some could argue that's like basically a physiologic dose or physiologic dose of steroids. So it's like really contributing to the pain relief the patient is experiencing. I'm not so sure. But some of these other immunosuppressants could cause neurologic issues that might affect the way that the patient senses or feels pain in and of itself. So challenging and interesting, but so many great points. But as far as putting my money down, yeah, I think I'm going to say that this is malignancy. Probably lymphoma of some kind, maybe PTLD, as Alec had mentioned, though usually that presents with a syndrome of lymphadenopathy, but my illness script is not robust for PTLD. So I'd just be interested to learn more. But Alec, what are your final thoughts before Ibrahim teaches us?
No, this is an awesome case. Thank you so much for sharing. Yeah, the LDH is always a little tough. I think it's the clinician that ordered this obviously went into this with a suspicion for either malignancy or some sort of infiltrative infection, which is super interesting. I think I would be interested to know is if the anemia was significantly worse than baseline, or if the other cell lines, even though if they were quote unquote normal, whether or not they had changed from the patient's prior baseline as well. So I think that would be interesting. Also, like if we have this information, the EBV serostatus of the patient and the transplant, I think would be interesting to know as well, since frequently PTLD is associated with EBV. And yeah, I mean, I haven't seen much PTLD. I haven't taken care of transplant patients since residency, but most of the patients I had seen just had significant cytopenias and then diffuse lymphadenopathy. So, a lot of times, at least my physical exam skills aren't super robust to pick up lymphadenopathy, and unless it's pretty blatant. So, a lot of times we just pick that up on imaging that's done for other reasons. So it'd be interesting to know when they did the MRI, or if the patient had other imaging, what did they notice lymphadenopathy that maybe we're not necessarily picking up on our exam. But yeah, the LDH is hard to ignore. It's extremely abnormal, and we don't have the patient isn't clearly hemolyzing. They're not infarcting tissue as far as we can gander from the vital signs and the rest of the physical exam and history that we've been given. So certainly rapid cell turnover and getting other markers of that, maybe a uric acid or calcium, other things would potentially be helpful. But lymphoma or lymphoma-like diseases can do pretty much anything. It's extremely humbling. So I think that would be my primary concern. And because the patient had a transplant, PTLD would just be somebody you could consider, or just a 33-year-old man presenting with an atypical presentation of the lymphoma unrelated to the transplant. Certainly possible, but just seems a little bit less likely. So yeah, I'll just pass it back to Ibrahim to maybe close the case.
So thank you all for the great discussion. I think all of you have already nailed the diagnosis. So this patient was actually diagnosed with post-transplantation lymphoproliferative disease, diffuse large B-cell lymphoma. And I think even though this patient's journey from the emergency room to the floor and then finally to the MRI and then to the histopathology that had confirmed the diagnosis was particularly interesting. I think the most interesting factor was actually the way by which this patient was managed. So usually patients with a PTLD would undergo R-CHOP therapy. However, because this patient had a history of recurrent kidney transplant, there was a lot of worry about whether or not they're going to have another graft versus host disease if they're going to undergo further immunosuppression. And I think the thing that I've learned the most from this case is that if you start a patient on R-CHOP therapy after they're diagnosed with lymphoproliferative disease, is that the rituximab can actually, you can actually stop the patient from taking the mycophenolate and the tacrolimus, and you can just start them on rituximab because it's equally as beneficial as both of these drugs. And this way you wouldn't increase the patient's risk for graft versus host disease. Another point as well is that just like you, Dr. Alec had mentioned, EBV remains a risk factor for this disease. And the patient had EBV serologies after the histopathology came back, not just because of the diagnosis itself, but also because we did not want to risk, again, another acute transplant failure following the treatment, and it came back negative. And then also the uric acid for this patient was 373. So.
Wow, thank you, Ibrahim. Such an amazing case. Like just reflecting back on the journey, I think overall, I feel like I know like one day I will encounter a case that's out of my comfort zone on the VMR, but I also really appreciate this such a safe space to expose my vulnerabilities or my blank, areas, but also very fortunate to also have Alec and Austin co-discussing the case together, but then really like focusing on learning and so yeah, I think thank you so much again for sharing the case.
Ibrahim, that was so awesome. I can't believe that was your backup case. I can't wait to see some of the other cases you typically have. And I guess, I'm not, reflecting on this. I think the absence of lymphadenopathy is just out of my sort of illness script for PTLD, but I need to do some more reading about that in particular. And, if you had any other imaging, I think that would be sort of just elucidating for me to know if like truly the only site of illness or disease that was found was that T6 area. And then also, I'm not sure if you had a chance to do a cognitive autopsy with yourself or your attending or whoever ordered the LDH and why they decided to do it, because it provided a lot of diagnostic momentum. And if I was alone, honestly, I'm not sure that that's a test that necessarily I would have ordered. I think I would have been waiting. I would have found that on the pathology for the bone. So I'd love to learn from you in that from that sense. Austin, what do you think?
No, I had a similar reflection, and so much knowledge gaps for me here. I need to read more about PTLD, more about bony disease, and but such an exciting case, interesting case. Very unfortunate for this patient, but hopefully they did well. It sounds like they had an expert team kind of managing and balancing the immune suppression. I'm wondering, Ibrahim, I don't have a lot of experience with this, but I know there's this sort of newer antibody that they use for renal transplants called like belatacept. Was that something that was brought up for this patient's care, or just the rituximab, like as you mentioned?
I think it was decided upon early on the R-CHOP therapy. However, I do have to say that targeted therapies do exist, but I think they're second line to R-CHOP just because of the cost, particularly here. And then also regarding Alex's point, regarding the PTLD, so everyone was actually thinking that this patient had osteoporosis, particularly because of the chronic steroid that they had been using. However, the attending explained further that even though it might seem that most of the patients would present with osteoporosis, particularly if they have chronic kidney disease or they're on chronic steroid use, you still have to consider PTLD as your second diagnosis in such patients. And until you roll out entirely PTLD, you cannot treat them as osteoporosis. So thank you all for the great discussion.
Thank you so much. That was wonderful. And I think it's on to Leah for the teaching points.
Yes. So thank you everyone for walking us through this case. I think it was very interesting to see how this case develops. And I think it was hard because for so long, as all of you also discussed, we didn't really have any systemic signature and didn't know what direction this case went. But it all started with back pain. And when we think of back pain, we can just separate them or divide it up or ask us this question: is it specific or is it non-specific back pain? So what does that mean? When we talk about non-specific back pain, it's more the common musculoskeletal. We don't exactly know why the cause. It might be more of a I'm losing my words. Never mind, it's more the non-specific back pain, and we're more worried about the specific back pain. So if there are any red flags, is there fever, is there history of malignancy, are there neurologic deficits, any signs of inflammation or weight loss? So these are all things that make us worried that this might be a more sinister cause of back pain, and that's why we call it the specific back pain. And here we asked us the question first. We only had the back pain. Are there triggers, things that make us think of more musculoskeletal pain? Or also the young age at first made us think of more maybe the inflammatory cause of ankylosing spondylitis. And after that, we discussed the fact that it was scapular pain. And scapular pain is also often associated with referred pain. So it might come from muscle. It was also mentioned that it might come from a diaphragmatic, or might be referred from there, from the upper back, and also biliary pathologies might present as scapular pain. So we discussed the scapular pain, then we discussed the intermittent nature. And intermittent makes us think of, is there a trigger? And if it's intermittent, for how long does the symptom present itself? Because it's a difference if it's intermittent, but it's there for a week, or it's intermittent or just a few seconds. And then also the pain was worse with exertion. And we asked the question, is it anatomical? Is it maybe a neurologic or a vascular cause? But we kept repeating that we're missing the systemic signature somehow in this case. And now we're coming to an important point in this case, which is the background, unintended, of immunosuppression and a transplant history. So we can also add to our kind of approach to back pain, what's the background of the patient? What do we have to be worried about? And here, because of the immunosuppression and the transplant history, we discussed it might be related to an infection, malignancy, TLD, graft versus host disease. Also, what medications is the patient taking? Maybe steroids can make them more prone to osteoporotic fractures, or the renal history to bone mineral diseases associated with it. And then also, again, we're coming back to maybe the patient might not present adequately, might not have the inflammatory response we're expecting because they are immunosuppressed because of their medications. And then we went on to discuss causes of muscle spasms. It could be due to electrolytes, but that was somehow unlikely because it was so focal. Then we talked about focal dystonias, and we came back to the pain or localized bone pathology, which was even more strengthened by the fact that on exam, we didn't really have much besides this midline tenderness and the paravertebral spasms. So that's why we discussed more, okay, this seems to be more of a bony pathology of the spine. And the imaging actually confirmed that when we had the MRI later on, and we saw a fracture, and then we discussed pathologic fractures. So what is a pathologic fracture? It's when the fracture is not happening due to an adequate trauma. And it might be because there's a cancer infiltrating the bone, weakening it. There might be something else, like an infection infiltrating and weakening it. Or other causes like steroid use, osteoporosis. So it's not a fracture we expect or should be there because of a trauma. And I think this is the most interesting part of this case today, which is the fact that this was thoracic spine back pain. And I love how you guys discussed that this also is kind of a red flag, because it's unusual. We usually just associate the red flags with the lower back, and thoracic spine is somehow unusual. It's also hard to test it because if we have cord compression, how do we test the reflexes for it? How do we test the strength in this area? And also we learned from Ibrahim that the patient had chronic steroid use, which made the spinal cord compression even less symptomatic. So this might not be related directly to the thoracic nature of it, but I think generally here that it was thoracic made us worry even more. And in association, of course, with the background of the patient. Then we discussed shortly the LDH. So LDH can be elevated in cases of high cell turnover, tissue damage, like a rhabdomyolysis can cause a high LDH, and heme malignancy can cause really high LDH as well, or hemolysis. And in the end, this patient did have a cause of back pain that was related to the background with immunosuppression and transplant. In this case, it was PTLD, the post-transplant lymphoproliferative diffuse large B-cell lymphoma. I kind of regret starting that long word, but PTLD in short. And we learned this pearl from Ibrahim, which is that the R-CHOP treatment, that is the treatment for this disease, allows us to stop the immunosuppression this patient had before and continue, because the rituximab will kind of take over the role of these medications. That's at least how I understood it from him. And then also really important to have this link between EBV serologies or EBV infection in general and PTLD, and important to test that in case of this disease. So these are the teaching points for today. Thank you guys for joining. Thank you for the discussion and the case. And yeah, that's all for me today.
Wow, yes, excellent summary and teaching points. Thank you so much, Leah. That was superb. And just another great case in VMR. Thanks so much, everyone, for joining. I hope everyone has a great morning, afternoon, or evening, wherever you are. Bye-bye.
Thank you so much. Bye.